Now, if moving on to the next section, as we are dealing with cerebral palsy, if a child is brought by the parents that he is unable to sit properly or there is history of delayed milestones, then how to assess whether this patient has cerebral palsy or not. In this section, we'll be going through how to diagnose cerebral palsy, what are the different type of motor disorders, how to make it a diagnosis, how to assess gait. If a child of that kind of age, for example 5 or 7 years of child, comes in who is unable to walk properly, then yes, on these children you can do the gait analysis. But usually it's always the infants which presents within the first year of life, in which although they're not walking properly, but there is always history of delayed milestones. So what are the different types of motor disorders associated with cerebral palsy? These include spasticity, that is the most common. Why it is most common? Because it's an upper motor neuron lesion, usually presents with spastic paralysis or paresis of the muscle. As I just told you, it's the most commonest form and involves the pyramidal system damage, that is the corticospinal tract is damaged. There's increased muscle tone and hyperreflexia. The passive movement is actually resisted and they are unable to perform their daily activities like walking, grabbing something by their hand or arms. Next form is ataxia. Some of the patient may, instead of spasticity, they present with muscle ataxia, that is cerebral involvement, usually associated with hypotonia and loss of muscle coordination. The first thing which really comes into mind is probably some kind of cerebellar pathology, but actually it's not the cerebellum, but the tracts all are affected. This is usually due to cerebellar damage, can be as present as well. Poor balance and wide base case, because they are unable to control their movement and coordinate their movements. That's why this is usually seen in the patients with this kind of ataxic gait. They usually have wide stepping gait and they are unable to initiate their gait. Once they are able to initiate, they are unable to control the speed and movement, and as a result there is a highly shuffling kind of a gait in these forms. Then there may be a mixed form. For example, there may be some muscles may be in hyperreflexia and hypertonicity, and some may be hypertonic and hyperreflexic. Usually, the tone abnormalities are more common. Spasticity with dyskinesia is seen in these mixed forms. Then there's a rare form called as hypertonic form as well. Although completely hypotonia is rare, but yes, it sometimes is present along with hypertonia, or it can be present in isolated form as well. And then less likely, rarely, it is a dyskinetic form as well, which is further subdivided into two forms. One is dystonic, which is abnormality of tone, or this is associated with hypokinesia and hypertonia, or choreothyroid, which is called as hypokinesia and hypotonia. Now, if you see why it is difference over here is in the dyskinetic form, in the problem is with the kinematics, that the problem starts whether initiation of the gait, propagation of the gait, and eventually termination of the gait. Now these when due to these kind of problems, they are unable to control their movements in a way that they are unable to initiate a movement, control the speed of the movement, and terminate the movement they want to carry it out. Therefore usually associated with dystonic or choreoarthritic movements of the hand limbs as well. So if usually the child comes within the first year, the parents complain if there is something wrong with our child, he is unable to, there is maybe a feeding problems as well, there may be milestone is maybe delayed as well. So what are the different milestones which are delayed during the first year of the life? Because usually a child starts walking by 1.5 years. So if the walking abnormality they would present, that is very late. They usually present at 5, 6, 7 years of age. Now when the parents come with a child of that kind of age, they say that he is unable to walk or sit properly. But when parents come with an infant, usually there is always history of developmental delay in the milestones. There may be history of pre or perinatal event, like there was some kind of infection, like torch infections during pregnancy, there was some kind of anoxic insult, or this child suffered from some kind of a meningitis post birth. There was epileptic fit as well. There may be history of epileptic fits in the child or the mother as well. So all these are actually clue that there was some kind of neurological damage which happened either around the perinatal period. Then usually neonatal ultrasound scan can be done actually to assess whether the pyramidal tract is intact or not. Other symptoms which include is difficulty in suckling and swallowing, excessive drooling in these children. Then there may be other reflexes which may be present as well. Usually they disappear by 6 to 8 months, but they may be present as well, like primitive neck writing reflex. Asymmetrical reflexes may be, some may be, in some cases it may be a hypertonic reflex, and some there will be hyperreflexia. For example, symmetrical tonic reflexes may be positive. Moral reflex usually which disappears is positive in these children. Then there will be extensive thrust response, that is that if the it's classically is seen in the children which have a spastic paralysis of the muscle. At birth, there is a motor behavioral control, protective and postural reflexes is usually seen. In these children, within the first year, there is gradually disappearance of the different reflexes as the neurovascular structures mature over time. But as their neurological status is poor, therefore this nervous system is actually not maturing over time. As a result, sometimes the primitive reflexes are positive in these children. Even the age has actually crossed, but they have crossed that kind of a age limit by which these reflexes become negative. So if a child comes around 5 years, 6 years, 7 years of age, then there will be the classical symptoms include the gait problems. The first thing with the parents would come is that he is unable to walk, or he is unable to stand, or he is unable to carry out even do the basic things which a normal child can do. There is, if for example there is a monoplasia, only one of the arm is involved, one of the leg is involved. Usually other, because other muscular systems are okay, therefore they can do their daily activities, but there is increased tendency of trips and falls, especially over the uneven surfaces. That patient comes and complain that he usually falls, especially over the uneven surfaces, and he's not able to walk. Then there is multidisciplinary team assessment is sometimes required, because there could, when 5 to 7 years have passed, there could be multiple other problems, for example viral infections and other neurological complications, which instead of having a cerebral palsy, the patient may be suffering from that kind of a problem. So we have to observe and examine that child for sitting, standing and walking. That is where the gait analysis comes in, and we need to analyze the gait so that we can exactly know whether what kind of muscles are working and what kind of muscles are not working. Usually evaluation is through the GMFCS system. General motor function classification system is basically based on different patterns and different severity of disease. Usually we see is whether child is able to climb stairs or not, whether he or she is able to walk on a even surfaces or not, and whether she is able to balance his or her posture over the uneven surfaces or not, whether he or she is wheelchair bound, whether he or she is electric wheelchair bound, depending upon the severity. And sometimes there is so high degree of severity that they not only need electric wheelchair, plus also need some kind of head support as well, because they cannot even hold their neck properly as well. So it has 5 grades, and depending on different grades, it actually comes in different areas. Gross motor function classification system is actually used, and the main function to assess is actually their motor functions, and that is what actually determines the treatment as well, that how much motor function is present at this time, and what is actually the desired motor function we want in this child. Now, as the child grows in, the other things which need to look at is sitting posture. As I just told you, usually it's difficult for them to sit, and sometimes impossible as well. Hypotonic trunk, kyphotic posture. Usually there is thrust into extension, and scoliosis or pelvic obliquity is present. Now, standing, we have to assess their standing posture as well. We have to see whether hips are flexed or not, is there associated flexion deformity as well, they're adducted or not, and whether the hips are really internally rotated or not. This is the classical representation. If you see this diagram, this is the kind of a presentation they have. Their hip is flexed and internally rotated, knee is flexed, with along with the ankle is plantar flexed or in form of equinus. You have to look at the pelvic obliquity as well, because they're associated scoliosis as well, and they have poor muscle balance. Then we have to go for the neurological examination, which includes muscle tone and power, how much muscles are spared and what are the group of muscles involved, range of movement, whether it's an upper or lower motor neuron lesion, what is it spastic, what is the associated problem, like it's hypertonia, hypertonia, spasticity, or something like that. Now, if the child comes at this age, then we can do the gait analysis as well. The gait analysis actually tell us whether exactly where the problem is. For example, clinical gait analysis can be done. Usually, it's difficult because there's sometimes they're associated flexion contractures of the hip. There may be a scissoring gait. The scissoring is actually a classical sign of the cerebral palsy. In this child, the two legs are crossing in such a way that it looks like a scissor, and sometimes that's why even proper gait analysis is not possible. So even by just examining the child, we can safely say that it is likely cerebral palsy. But usually, swing phases of gait in coronal, sagittal, and transverse plane is measured in this form. There are multiple electrodes which are placed on the body, and then there's a computer program which actually assesses the muscle contraction, the tone, and everything, and the angle by which the knee is flexing and ankle joint is moving, and all that is actually assessed. Then computerized gait analysis are also nowadays, which also mean kinematics and kinetics of the body. There's also associated with electromyography as well, the how much muscle is contracting and what is the force of the muscle which is by which contracting are all actually measured. And then there is pedobarography, or in which actually there is deformed foot abnormalities in these. So pedobarography is also done, that how much pressure is actually being taken by which part of the foot, and how much problem is there in which area of the foot and ankle joint. Then metabolic energy analysis can also be done, because they usually with the limb they have very high energy expenditure for walking, so they have to use a lot of energy to walk. Therefore, metabolic energy analysis are always helpful in these children as well. Then specific patterns sometimes may be present as well. One is called as windswept phenomena, other is a scissoring gait. We have to analyze whether what kind of a pattern is clinically present in these patients. There may be a video recording which can be later on viewed by different experts, because now with the advent of technology, it's very easy to record everything and then we can analyze it later as well. There may be identification of dynamic components, which is very helpful with computerized gait analysis. Now, first we have to determine whether it's a fixed or flexible contracture, and then what can be done with regarding this contracture. And usually there is contractures of the hip, knee, and ankle. They're always almost associated, because with a progressive disease there is always a problem in these children. If before we determine this, we have to determine whether the degree of deformity is there or not, or whether if it is a flexion contraction at hip, how much it is. Then the next thing is whether it is associated with length of each muscle tendon unit is important, because whether there is quads tightness or whether there is hamstring tightness. Then if once we determine that, then we can do for determining whether gastrosoleus is tight or only gastrocnemius is tight. For that, there we have silver skeloid test which can be done as well. Then we have to check for the hamstrings as well. An x-ray of the subluxation of the joint is important, because we have to get knee, hip, and ankle x-rays as well, whether they may be associated subluxed dislocated hip, or there may be associated subluxed knee joint, or there will be dislocated or subluxed ankle joint. There's degree of how much degree of muscle contracture is there, that is also important. And sometimes these children have a typical movement, for example, to avoid certain things they have, because one muscle group of muscle is not functioning properly, so they do a certain movement so that that can be carried on to the other side. In this section, we have gone through how to analyze to diagnose CP. whether there is associated with motor reflexes, or there may be associated with deranged reflexes at the infant age, or there may be associated with motor abnormalities when the child comes by 5 to 7 years. So by this we can actually either do gait analysis if the child is walking, that could be clinical, or that could be computerized as well. We can do different tests as well to see whether exercise can be done as well, so that whether the hip is subluxed or not, knee is dislocated or subluxed or not. Then we can see that whether the different muscle groups are tight, if they're tight, how much tight they are. And all this can be done actually to first to assess what is the severity of the disease. Once we know the severity, then we can plan for the proper surgical intervention or what kind of treatment we can give to the patient. That's all from this section. Thank you very much. Keep watching sqadia.com.